Hello, everyone. If you'll just grab yourself something to drink or nibble on if you want, we'll get started in just a couple minutes. Hello, everyone. Let's get started. There'll be time afterward for more mingling, but I want to say a big welcome to all of you. I'm so pleased that you braved the weather. You know, we're in a drought, so it chose to rain on this particular day, unfortunately. But anyway, welcome, everyone. I'm really pleased to be here. I'm Tonda Hughes, professor in the School of Nursing and the director of the Center for Sexual and Gender Minority Health, which I co-direct with Walter Bachting, who unfortunately is teaching a class right now, and so he's not able to be here, but hopefully he may be able to come a little bit later. In alignment with our school's commitment to social justice and health equity, Our center aims to support both established and new investigators who are committed to improving the lives and the health of sexual and gender minority individuals. We do this primarily through education. We work with our pre-docs, postdocs, and other students and new faculty. And we do that by holding events like this and other sorts of events. And today we're so fortunate to have Dr. Jae Sevelius, who is an internationally recognized leader in transgender health, whose research, I believe, exemplifies the goals and values of our center and the School of Nursing's mission, and who is an affiliate of our center, so we're really pleased about that. Dr. Sevelius is professor of medical psychology in the Department of Psychiatry at Columbia University, and a clinical psychologist, behavioral health researcher, and intervention scientist who has extensive research and extensive portfolio of NIH-funded studies that focus on the health and resilience of transgender and gender expansive individuals and communities. Dr. Sevelius developed the Model of Gender Affirmation, the first trans-specific conceptual model that aims to elucidate the role of gender affirmation on health-related behaviors and outcomes. Jae's groundbreaking work includes the design, testing, and dissemination of community-based, peer-led interventions that promote sexual health and resilience, particularly among transgender women of color in New York City, the San Francisco Bay Area, and Sao Paulo, Brazil. Recently, their research has expanded to explore the potential of psychedelic-assisted therapies for addressing identity-based trauma. In addition to their outstanding contributions to research, Jae is a dedicated mentor to early career investigators, particularly those from underrepresented backgrounds in academic medicine. Jae's passion for creating inclusive, equitable, and transformative academic environments is near and dear to my heart and is evident in their advocacy and leadership. Today, we're honored to have Jae with us, so please join me in giving Jae a very warm welcome. Thank you.
Thank you so much, Tanda. I so appreciate that, and I really appreciate this turnout. It's just so lovely to see so many familiar faces, supportive folks, and I'm really happy to be here to give this talk. I am going to be talking about designing interventions for impact. So it was an interesting talk for me to put together because I'm not going to be presenting my science per se, although I will be using my science as an example of how you develop interventions. And what I really wanted to do, and when I was invited to give this talk, was more about how do we think about moving from observational studies, from cross-sectional surveys, from documenting that health disparities exist to designing interventions that are truly going to be meaningful for the communities that we really want to support, create, do meaningful work with, to really address these health disparities and ultimately eliminate them. So how many people here already do intervention research? Okay, we have a good turnout of intervention scientists, so I would love to hear from examples from your work as well. Other folks, anybody considering maybe doing some intervention work in the future? Yeah, lots of folks. Okay, great. So I'm really looking forward to the Q&A at the end, and I'm gonna try to not talk too much so that we have lots of time for discussion. Just want to acknowledge, thank you, Casey, for also bringing this up earlier. Yesterday was the Transgender Day of Remembrance, which is an annual acknowledgement of the trans people that we've lost to transphobic violence. And I believe it was created in 1999. So this may be the 25th anniversary, if I'm not mistaken. But basically a way to acknowledge the huge disparities in transphobic violence, harassment that our communities face, and I think a really important day for us to acknowledge. So I've been doing intervention research really since the beginning of my career because I am trained as a clinical psychologist. I think a lot in terms of working very directly with people and what's meaningful in people's lives, and maybe in communities as well. But I really, as a researcher, really wanted to do research that I felt like was making a direct impact on people's lives. And so I was immediately drawn to thinking about programming, doing research to really understand what kinds of needs the community had and how I could do research that would help create programs and systems and interventions that really felt meaningful to the people that I wanted to work with. And I also wanted to work directly with community. There are lots and lots of different ways to intervene on systems and structures, working with providers. But for me, my passion was really with community, so I really wanted to be immersed in community. So that's kind of the context. Today, I'm not going to talk about all of these interventions, but this is just sort of to acknowledge that the interventions that I've developed and tested, they've all kind of gone on to have a life of their own and have interesting trajectories, and I can talk a little bit about some examples of where these interventions have gone in terms of research and dissemination. So I'll talk a little bit about why do we want to develop interventions? It seems like this is a crowd that already knows why we might want to develop interventions, and why would we want to engage community in our research approaches to developing these interventions? Why can't we just create something and hand it to community? And so I'll talk a little bit about some frameworks that are really useful for thinking about moving from observational studies to intervention research and dissemination. And so these are really useful if you're thinking about writing a grant, for example, to develop an intervention. It's really important to select a framework to guide and create a map for your research and how you're developing that intervention and where you're going to take it. I'll talk a little bit about some of the advantages and also the challenges of engaging community in intervention development research, because there are both great things about it and there are also things that can be hard. And then we'll do the Q&A. So as this esteemed audience already knows, thinking about moving from knowledge to action is really important, especially when we're talking about health disparities. Just knowing that health disparities exist or inequities exist doesn't necessarily tell us what to do about them. We might think we know, and there is research that we need to do with community to really understand how those health inequities show up in people's everyday lives, what their priorities are, and sometimes when we don't center community priorities, we will move the wrong solution forward. We think we know, and maybe it's a solution for one problem, but there's a problem over here that is taking up people's energy and is really their focus and their priority. We can also move the right solution forward in the wrong way. We saw that in the early days of PrEP, where it was all about gay men, and trans women were like, hello, I guess PrEP's not for me. And so really thinking about, what do people need to really, even if the solution might be right for them in some context, let's make sure we're moving it forward in the right way. Sometimes and I see this sometimes with early career folks as well, where they're really focused on a solution. I have this solution and I want to bring this to community. So sometimes we already have a solution in our mind for a problem that we think exists, and that problem actually may not exist or may not be the most important problem. And there are a couple examples of this that I think are really telling. One is, there was a malaria outbreak in fishing villages in Malawi, and there was a group that came in with insecticide-treated mosquito nets, and they said, well, we'll just distribute these mosquito nets so that people have nets and can prevent malaria. It's a pretty easy solution, right? Well, it turns out the fishing villages were food insecure and really needed more supplies for fishing, so they used all the nets, the mosquito nets, for fishing, instead of, they're supposed to be draped over the bed and that prevents you from getting bitten from mosquitoes. But using these nets for fishing actually caused problems in the marine ecosystem because the nets were not designed for fishing. They're very fine mesh, and they were overfishing with these nets, and then insecticide was also getting into the water supply. So the food insecurity was actually a much bigger priority for the community than malaria was. And so the folks who came in with this predetermined solution ended up creating other problems that then needed to be addressed. The other example is like these large-scale campaigns that we saw around voluntary medical male circumcision in sub-Saharan Africa. I don't know, maybe it was 20 years ago now, where it was like, this is the answer, you know, just circumcise everybody. But when you try to roll something like that out in a context where you haven't understood community norms, religious norms, cultural norms, and what folks were prioritizing, which they really wanted more education around HIV transmission. They wanted different things, and they actually, there wasn't very good uptake of this solution. So those are some examples about how community-engaged intervention research can actually help us come up with better solutions that address real problems and ultimately better science. So this is the definition of community-engaged research that Minkler and Wallerstein offered in 2003 when NIH was really starting to get more on board with really emphasizing community-engaged research. And so the idea is that the approach is equitable, involving all partners in the process, recognizing the unique strengths that each bring, beginning with a topic of importance to the community, with the aim of combining knowledge and action for social change, ultimately to improve community health and eliminate health disparities. So when we're thinking about intervening, you can intervene. This is a very familiar Bronfenbrenner socio-ecological model. You can intervene at any of these levels. Interventions can happen at the individual level, behavioral interventions, which is where I tend to focus at more the individual interpersonal level. But structural level interventions have really become very urgent as well, and we recognize that policies, obviously in this current climate where we're all feeling a little bit, maybe a lot, nervous about the administration change that's impending, we're thinking a lot about policy and how policy changes that are potentially impending could impact our communities, our research, and so it's really important to think at that level. You know, while I feel like structural interventions are absolutely urgent, I also feel very passionate that we need to work with communities on the ground and really help people today in their everyday life, in the current context. And as a clinical psychologist, I feel like that's where my strength lies. So some people will ask, well, you know, why don't you focus on structural level things? I'm like, I'm not actually trained to do that. I think about those things and I think about the context, especially in Brazil. When I started working in Brazil and thinking about policy contexts there and how differently the health systems are set up, these are things that we really had to learn a lot about and think a lot about with our community partners in Brazil in order to move forward and adapt interventions that were actually created in the US context. So when you're intervening at these different levels, you might have a different community that you're engaging. So really thinking about community-engaged research may look like working on the ground with community, but if you're intervening at the policy level, you may want to talk about the impact of policy on people's everyday lives in community, but you're also going to be wanting to engage those policymakers, other stakeholders, and so the community that you're engaging really depends on the research question that you're asking. Community-engaged research also goes by many names. So kind of depending on the discipline that the terms are coming out from, you may hear it referred to as community academic partnerships or participatory action research. Research practice partnerships kind of comes out more from the educational sciences. And then community-based participatory research might be maybe the most commonly known, which really comes out of social justice movements in the Global South, Paulo Freire's work, and we tend to use CBPR, that terminology, very flexibly in public health, but CBPR is actually a pretty complex model. It's for engaging communities, and I'm not going to go through this whole slide, but just wanted to give you a sense of how complex CBPR actually is. And I've seen sometimes in NIH grant sections, reviewers will push back if you use the term CBPR and you don't really use CBPR in this more complex sense. So community engaged research tends to be the favored term at NIH. But CBPR really covers this whole spectrum of thinking about the context in which you're developing your intervention or program, the partnership processes, so who's involved, how are they relating to each other, what's the structure of the partnership, who are the individuals involved and how do they impact the processes. And then in terms of the intervention and research, thinking about how those processes, are they empowering to every member of those partnerships, how is the community involved in research, and then how does that impact the outputs with the outcomes, really long-term wanting to impact, transform communities, achieve social justice, health equity. But CBPR can be very challenging to implement in the context of sort of NIH funding cycles, NIH funding priorities. You'll get the RFP and you have 2 months to write the grant, and your community partner doesn't yet know what you're talking about. It can be very challenging to do more traditional CBPR. So when I think about community engaged research from the CBPR perspective, I think about it kind of longer term. You're really thinking about the context and that those partnership processes may evolve and change as your research trajectory evolves and changes. But I think there's a lot to learn from this model. Overall, I think these 5 elements are really sort of the core principles of community engagement. If you look at these different community engaged models, the emphasis is really about cooperative and co-learning processes, so really acknowledging that learning is bidirectional. Often researchers will go to communities and say, let me tell you what we're doing. Let me tell you what your problem is. Let me educate you about our methods. But really it's about this co-learning process. The capacity building is also mutual. So developing the capacity of researchers to really engage with community in a helpful way, but also increasing the capacity of community organizations, community members themselves to engage in research. Building on existing community strengths. This is a big one. When I first started working in intervention science, one of the first things I noticed was that the trans communities that I was working with already had their own networks, information networks. They already had their own community leaders who they went to and trusted to get health information from. They would accompany each other to health care appointments, and that was something that we built on. And so really understanding what the strengths of the community are, and then helping to create some resources and infrastructure to shore those things up. Power sharing and reflection around privilege, that's kind of an obvious one where if you are the researcher with the funding coming into community, you may have a certain type of power in that dynamic. Reflecting around privilege, depending on sort of your intersectional social position, you may or may not have power in different relationships or in different contexts. And so just kind of reflecting on that in sort of a dynamic way, and how those processes are playing out in different situations is also a core principle of community engagement. And then long-term commitment. This may or may not look like a long-term commitment to working with a particular organization, for example, but a long-term commitment to working with community, in community, and learning from community, I think is really at the core of that principle. Further, the way that community is involved may look different at different stages of the research process. When you look at different research projects, sometimes they'll have like a community advisory board that may fall more in that consultation role. That's not necessarily the most intensive way of engaging communities. It may be appropriate for certain types of projects, but I just wanted to sort of point out that there is this spectrum of how community can be engaged in different research, and that shared leadership is really sort of the ideal. in terms of really making good decisions about interventions and implementations and creating really strong partnerships. The other thing about that too is that community dependent, like the example that I gave earlier where, if you're, say, intervening on a health system and wanting to, put gender affirming options into EHRs for patients where multiple, the person's gender identity can be marked correctly, name issues, things like that. You may want to engage with patients really intensely at the beginning of the project and then move to working more with providers and understanding the provider context. What does that look like, making changes to the EHR from their perspective. You may have to work then with IT systems that are making edits to the EHR. Once you make those edits, then you're more engaging with providers to train them on the new system. Once that's implemented, then you're engaging with patients to see what the outcomes on patient experiences might be. So the ebb and flow of how you're engaging with community over the course of the project can change, but the important thing is that you're being really intentional about it and really engaging the community in a way that's appropriate to the research question at that stage. So this is the NIH stage model for behavioral intervention development, and what's great about the way that they lay this out is it sort of provides a roadmap for understanding where your research lies and where it could go, what the next step is in that stage. I've done research at every stage of this model, and that's challenging too, because what ends up happening is there's new methodologies to learn for every stage of this model. Once I moved into more implementation and dissemination research, there was a whole new language to learn around that. And so intervention science can be challenging in that sense if you're really kind of shepherding your interventions through this process. Some people's entire careers stay at stage 0 because they're epidemiologists. Stage 0 is basic research, so that's epidemiological studies, cross-sectional surveys, longitudinal observational studies. It can also be qualitative research, so understanding the context of how people are experiencing certain health inequities. And this is incredibly important research because it one, documents that inequities exist. Steph Baral, for anybody who was on the HAB Grand Rounds earlier today, presented a ton of really important epidemiological research kind of pinpointing where certain inequities lie, what structural determinants are driving those inequities, and that helps us to target interventions better and also to think about which communities to prioritize and how. So it's also can be theory generating. So basic research is also around looking at mechanisms of change. And so if we're wanting to target certain behavioral mechanisms, we're going to look to basic research to help us inform our interventions. Stage 1 is intervention generation and refinement. That can be adapting existing interventions. It can be building components of new interventions. I'll talk a little bit about adaptation versus development in a bit. But stage 1 is also pilot testing for acceptability and feasibility. So you're kind of starting small, developing your materials, developing and testing them with small sample sizes and refining them. Stage 2 is efficacy testing, and this is what we think of as our more traditional sort of clinical trials, randomized clinical trials, cluster trials, things like that, where you're working more in research settings with research providers, so it's very tightly controlled. Like, does this intervention work in the ideal context where the research is really shaping the implementation of the intervention? Stage 3 is efficacy testing in, like, quote unquote real world settings. So testing the intervention with community providers in community settings and with all of the messiness that can come with that, and does this intervention still work in when you don't have as tight controls as you do in the research setting. Stage 4 is effectiveness. So sometimes people will talk about this, the hybrid designs falling into this category. So once the intervention is out there in the world, does it still work? You know, when implementing by community, for community, in community settings, do we still see fidelity to the intervention is a big question in effectiveness studies. Can people continue to implement this research or this intervention in the way it was designed? Stage 5, implementation and dissemination. These, you're really getting into, like, can CBOs or NGOs adopt the intervention, deliver them with fidelity, and how do we encourage broader scale adoption? Is the intervention sustainable over time, and how do we scale it up? So I'm going to talk a little bit about some examples from my own research. We already talked about the basic research, also referred to as discovery studies, sometimes formative work, and really important for developing theory. Stage 1, intervention, generation, and refinement. So some frameworks for development and adaptation that are commonly used. Engage for Change is a very community-engaged intervention development framework. Intervention mapping is also a development framework where you're really starting to develop an intervention from scratch. The map of adaptation process was developed by CDC, and then ADAPT-IT, which is my personal favorite, not just because Gina Wingood is here at Columbia, but I actually started using ADAPT-IT way back in the day, wrote a K that included it, and I think it's actually the cleanest framework, and I'll talk a little bit more about that. But when you're thinking about developing an intervention, how do you decide whether you're going to adapt an existing intervention or develop one from scratch? And there are benefits to both. When you adapt an intervention, you're building on an existing base that shows that this intervention works. Usually you choose an intervention that already has some efficacy data, so it's not also a brand new intervention that you're then adapting for a new population, but it's an efficacious intervention in one context that you're adapting for a new context. And so you have that evidence base in a different context to build on. It's also a more efficient use of resources and time because you kind of have an infrastructure to work with, a starting point to move from. Whereas when you're developing a new intervention, sometimes new ideas will emerge from kind of starting from scratch, and community might be more invested in developing something new. They may be wanting to really own that intervention and really have it feel homegrown in that sense. So you may sometimes get more buy-in from community that way. And you can also start from the most current evidence. It takes a long time for an intervention to establish efficacy, so sometimes it's based on old, outdated contexts. Like PrEP is a good example. When I first started, PrEP did not exist, and then I developed some interventions and then had to go back and adapt and incorporate PrEP, and so the research context evolves, and starting from scratch can start from the most current. How many people are familiar with the ADAPT-IT framework? Oh, a few. Good. This is Gina Wingood and Ralph D. Clementi published on this model in 2008, and I think it's still incredibly relevant because it's really just a map. What is the process for adapting an intervention? And it starts essentially with understanding the population. That's the basic research. Then doing sort of a survey and really looking into what interventions are out there that we could possibly either adopt for our community or adapt them to our community. And then you create an adaptation plan and goals. And the adaptation plan often draws on some theory, some behavioral theory, your theories about the mechanisms of change, the mechanisms that you're seeking to address or target. And often you'll do these first 3 steps before you even write the proposal to do the intervention adaptation, because you're writing about you have to kind of write about what's out there already and what your plan is for adaptation. So typically speaking, you're going to want to do some community engagement even before you get to into the adaptation plan and writing that grant. Production, of course, then you have to kind of produce the drafts of adapted materials and the activities. This step, for some reason, often gets overlooked when people are writing grants. That we're going to adapt the intervention and then we're going to pilot it. There's a huge amount of work in between those two. Like, we're going to create the adaptation plan. You have to create the materials. You have to test the materials or run them by your community, the community that you're going to be implementing them with. Go back and refine based on your feedback. Try again, and then you have to train your staff. And that's another thing that can take much longer than people necessarily anticipate. Then the topical experts, that may be community folks, it may be medical care providers, depending on your intervention. The content you may be doing some health education and need medical staff input on those. Integrate the feedback, then you have to train folks, and then you're ready to pilot test for feasibility and acceptability. This stage is also controversial in the NIH world, where people will often talk about estimating sample size for their R01, and a lot of NIH reviewers don't like to see that, because small pilot studies, when you have such a small sample size, you have very unstable results, and so it's very, very difficult to have a lot of confidence in effect size estimates based on such a small sample. So people will often try to walk a middle road and say, we're going to do these effect size estimates, but we're not really going to have a lot of confidence in them. Really, the pilot test is about feasibility and acceptability at its core. Does it work? Can you do it? And do people like it? So I always really try to emphasize that with trainees that are pilot testing new or adapted interventions. Intervention mapping is very similar, but is more around developing interventions from scratch. So there's a lot, they have a very involved process for kind of integrating theory into the intervention, which I think is really important. And something that is also important in adaptation, but often when you're adapting an existing intervention that has an efficacy basis, it has theory sort of integrated into it. So some of the common steps across many of the frameworks are essentially what both adapted and intervention mapping does, whereas you start with community priorities, develop a model of how is this intervention going to work? What behaviors are we trying to change? What is sort of the existing situation? And theoretically, what are those mechanisms of change? Develop and adapt materials, get feedback, conduct a pilot test, and then you refine based on the pilot test to address any challenges that you encountered. So just to talk a little bit from an example from my own science, this is basically what we know from existing epidemiological data. We know that the context of stigma, whether stigma is enacted through policies, enacted through structures, institutions, individuals, all of these forms of stigma impact trans people's mental health, and that in turn impacts behavioral health. So encountering stigma in healthcare contexts can lead people to avoid those contexts. Things like substance use for coping, lower levels of PrEP and HIV treatment adherence, and then that impacts health outcomes, and we start seeing the health inequities manifest at the individual level. So early in my career, I did a lot of, I don't know why this monitor just turned off, but I did a lot of qualitative work around understanding this phenomenon of gender affirmation, where I did a lot of focus groups, individual interviews, and as a clinical psychologist, of course, that qualitative interviewing is one of my favorite things to do. But really learning more about how people thought about the impact of gender affirmation in their lives and the importance of gender affirmation. And Initially, I was really focused on this idea of psychological gender affirmation as well as social, because I tend to function and look more at the individual interpersonal levels. But medical gender affirmation in terms of access to hormones, surgeries, affirming medical providers, obviously we know a lot more about that now than we did when I first started. And legal is another form of gender affirmation, so documentation, people's gender markers, things like that. And these are all very interrelated. And so I started looking at the variability in access to gender affirmation and need for gender affirmation. So it's not a one-size-fits-all kind of concept. Trans communities, gender expansive communities vary a lot in how strong their need is for, say, medical affirmation, access to supportive relationships. And so I did a lot of qualitative work to sort of understand the differences and how we might think about gender affirmation and increasing access to gender affirmation as a way to address some of the health inequities that we're seeing in trans communities. So I developed this model, gender affirmation, and initially was in the context of HIV risk and really thinking about how a lack of access to gender affirmation, thinking about that pathway to the health outcomes that we were seeing. So higher rates of HIV, higher rates of negative mental health outcomes, and then thinking about how do we intervene at that piece around access to gender affirmation. Can we create behavioral health interventions around this concept of gender affirmation? So thinking about gender affirmation as an intervention on the effects of stigma, that relationship between stigma and negative health outcomes. I'll skip that. Less interesting. So, T-Sista was one of the first interventions that I worked on that was actually an adaptation of Sista, which ironically is also Gina Wingood's work. I swear I'm not stalking Gina Wingood's scientific career, but she's done some really good things, which includes this intervention called Sista, which was initially developed for African American women, and it was a group-based health education intervention, peer-led, and so I was super passionate, very excited to learn about this intervention called Sista because of what I was hearing in the qualitative work I was doing with trans women of color, and I thought, wow, this is going to be a really cool thing to try to adapt for trans communities. So we developed a resource guide. We actually it was really just around helping CBOs adapt Sista for their population. It was more of a capacity building project. But ultimately, that adaptation led to a new intervention where we renamed the adapted version of Sista to Shiro's. And Shiro's is a 5-session intervention. It was actually the very first HIV status neutral intervention that I knew of at the time. For all trans women of color, regardless of HIV status. And that was very controversial at the time. We weren't doing a lot of status neutral things, but I was noticing that, trans women's community were not segregating themselves by HIV status, and it felt really antithetical to community building to segregate people based on HIV status. Some reviewers pointed out some risks around HIV status disclosure and all these things. So we documented everything that happened in the pilot, and it turned out to be a really beautiful learning experience and actually very stigma reducing when someone in the group had never been tested for HIV and was really scared to get tested. And the folks, some of the women living with HIV in the group, said to her, it's really important that you get tested right away. It's really important that if you do learn you're positive, you get on treatment right away. Sort of coached her. She came back, said, I got tested. She was negative. But it was this really beautiful sort of mutual learning experience, and something that can't happen in the context of, say, if a medical provider was facilitating that group or was working one-on-one with someone. It's just really different when you're working through some of these issues around fear, stigma, health education in the context of community versus other contexts. At the time, I was also working very closely with Mallory Johnson, my primary career research mentor. And he had this model of healthcare empowerment that was more about working one-on-one with folks to learn how to set goals around healthcare. And one of the things that was missing from Shiro's, and that Mallory had developed an intervention around for unhoused gay men living with HIV, was this concept of healthcare empowerment. And so doing some one-to-one, peer-to-peer health education and health navigation, that I wanted to see how well that worked in the context of trans communities. And it was more about educating and empowering trans women to serve as health educators in their own communities and do some health navigation. So we created Healthy Divas, which was a one-on-one intervention, as opposed to Shiro's, which was small group. And this is an example of stage 2. So we did a 2-site efficacy test of Healthy Divas after doing a feasibility and acceptability pilot. We did it in San Francisco and LA with Kathy Reback was my co-PI at the time. And this was specifically for women living with HIV. So there was something about women wanting to do that really specific health HIV care work more one-on-one in more of a individualized setting. So we tested this. We found that HIV care engagement increased over time for the control group. We separated out by ART just to understand if people who were not on ART had a different experience, but there were no differences between those two groups. So that Healthy Divas was very well received in the community. So what we ended up doing was I started working in Brazil, and what we decided to do was to combine Shiro's and Healthy Divas into a multi-level intervention where we leveraged the strengths of the group and also the one-on-one work with the peer health educators to create Manas por Manas, which is kind of Portuguese slang for sisters for sisters. That was more of that stage 3 design where it was really more in a community setting and we were testing the efficacy to see if it worked there. I'll also talk a little bit about hybrid study designs. Manas por Manas and our another study that I'm doing now is more of a hybrid design where either you're emphasizing sort of looking at the effectiveness while studying the implementation, or you're looking more at the implementation while also collecting data on the effectiveness. So the type of hybrid design really depends on whether you're really wanting to collect more efficacy data or really understand the implementation. I won't go too much into that just in case that's not of interest, but we can talk more about that in the Q&A if folks want to learn more. So the hybrid studies, I think, are particularly interesting when moving more into the implementation and really understanding how do we take what we learned in these research contexts and understand how they're being implemented in communities. What are the barriers? One of the studies, Let's Be, is also this multi-level Shiro's Healthy Divas combination. We're implementing, theoretically, after the pause is over, theoretically implementing in New York and Detroit, where we're looking at this idea of, everything was offered in person when we first started. Then COVID hit. We had to move everything online, and we didn't know whether the interventions had the same efficacy when they were offered online versus in person. We had no precedent. We weren't doing anything online. So what we decided to do was to actually build the intervention around the idea that it would intentionally be offered in a hybrid format, because that's kind of the reality that we're living in now, and collect some implementation data around what does the hybrid look like for the community? What are the privacy concerns for people like zooming into an intervention session? Do people have problems accessing technology? Do the people who come in person, is it disjointed for them that there are some people on Zoom? And so really understanding like what is a hybrid implementation of Let's Be, which is this multi-level intervention, how does that impact the efficacy of the intervention, and how will that inform implementation going forward when we're looking more toward dissemination? This is just kind of the structure of the Let's Be intervention, and you can see how we kind of combine Sheroes and Healthy Divas to create a multi-level intervention. Interestingly, so this is what like a conceptual framework looks like for an intervention. This is also something that is really important just from a grants person perspective, to really map out how you think that your intervention is going to work. So kind of delineating the theoretical foundations, we're building on intersectionality and gender affirmation, working with transgender women of color. The core elements of the intervention are that it's peer-led, it's status neutral, so HIV status neutral and trauma informed. The intervention components, this is a multi-level, so it's both group level and individual level. The mediators are the mechanisms of change, the things that we think we're going to impact by implementing these intervention components. The behavioral outcomes, so we think that people are going to decrease their sexual risk behavior, positive coping, self-care. That should be an upward arrow. We're going to increase care engagement. And then how are those behavioral changes ultimately going to impact the HIV outcomes? And so because this is a status neutral intervention, we're looking at both PrEP uptake and adherence, as well as viral suppression among participants living with HIV. And so, because Healthy Divas, we have a strong evidence base. We've been building over many, many years. We've had a few different grants, one in particular from the CDC as part of our Prevention Research Center, to study the implementation of Healthy Divas and to disseminate it. So as part of that Prevention Research Center grant, we built what we call a Healthy Divas Learning Center. And it's essentially a website that has a ton of tools for organizations who are thinking about adopting Healthy Divas or adapting Healthy Divas to their context. And so, how does an organization assess whether they're ready and have the resources to implement Healthy Divas? That's the preparing section. How do you train your peer staff to implement the intervention? So there are a bunch of training tools and training videos. Implementation, how do you document the impact? How do you monitor fidelity? How do you write a grant to get funding for your implementation? That piece is also in sustaining. So how do you think about sustaining the intervention? How do you fund it over time and continue to sort of monitor fidelity and document outcomes and things like that? So we have a ton of tools on this Learning Center. And I think it's interesting to think about the amount of resources that go into every stage along that NIH stage model of intervention development, because when I first started writing this grant, I kept having to look up, what is the difference between dissemination and translation again? It really is its own language, and learning about the different tools for monitoring what translation looks like. And so it's moving an intervention along this entire spectrum, really kind of become like that jack of all trades type researcher. The knowledge to action framework is this framework for public health where I like this, even though it's a little complicated looking, because you see the research phase in these blue squares where a lot of us sort of live. In these discovery studies, the epi studies, the efficacy studies where we're doing the randomized control clinical trials, maybe we're looking at implementation, but all of this stuff in the translation phase is really about how do you create products that people are going to use? How do you disseminate them? How do people know about your intervention? And then once people put your intervention into practice, how do you then get that feedback loop back to the researcher so that you can understand some of what's being learned in that implementation process. So the idea is that there really should be this feedback loop where you're continuing to revise and learn and generate new knowledge. So just to go back briefly to our community engagement strategies and thinking about how do you engage communities at these different stages of intervention development. And so in the formative stages, of course, me personally did a ton of interviews and focus groups. It's also learning about community priorities, engaging with community either through advisory boards or community partnerships. The intervention development and testing piece. I love intervention work groups. It's sort of like it's a working version of a community advisory board where you're constantly bringing them materials to give you feedback on your pilot testing activities with them, which essentially is what sometimes is referred to as theater testing. And then partnering with organizations on implementation studies during the dissemination and translation phase. We partnered with Oakland and CalPEP for many years, CalPEP in Oakland, as well as La Clinica in Oakland for several of our implementation studies. And then making sure that you're disseminating your findings in accessible formats. That's another piece of this community engagement that often gets lost, where we're not necessarily reporting back to the communities who were engaging in the research phase and really helping them to understand the impact of what they partnered with us on. Community events is also a really great way to do that. Some of the challenges in engaging communities in intervention development is these relationships can take a lot of time to build. Not all researchers have the time and energy to do what it takes to engage with communities in these ways, and it's a real investment. Community priorities may not reflect research priorities. So I mentioned PrEP earlier. PrEP was a challenge when it was first introduced for the communities that I work with. Trans women of color tend to have a lot of mistrust, especially for new biomedical strategies. They had a lot of questions about how is this going to interact with my hormones. There was no data about that. That was a real priority for our community, but was not a funding priority for NIH to really look at those interactions. So we actually built that into some of our PrEP studies early on, was looking at the interactions. But that can be you have to sometimes get really creative to make sure that the community priorities are built into your research. Limited mutual capacity and knowledge. So, if folks aren't part of the community that they're working with, there's a lot to learn. And sometimes sometimes that can be really challenging. Sometimes the capacity of the community to really learn about the research is also limited. They have their own priorities, their own hard work that they're doing every day, and they may not have time to invest. And then the funding and administrative barriers. I mean, this was something that has been ongoing, through my career, especially doing mostly peer-led, or actually, almost entirely peer-led interventions, where when we're doing efficacy studies in research contexts, we really wanted to hire people into the university environment. And communities don't always have the same credentials that the university is used to looking at when they're hiring for these positions. So we had to do a ton of advocacy within the context of the university to help them understand why our research team was really diverse and why we really wanted to hire the folks that we needed to hire. Creating equitable budgets between universities and organizations can be really challenging. It's very expensive to do research in the university context, and that lack of equity can create a lot of tension and issues on both sides. And then there is really no funding for partnership development. So with all the time and resources and energy that it takes to build these partnerships, lots of that, and most of that is unfunded. So it's pretty rare to find funding that supports that partnership development process itself. The advantages, though, I hope that the advantages have been clear throughout. We do better science when we prioritize community engagement. We ask better questions, we come up with better solutions, and then the solutions are more sustainable. Translating evidence into practice, so we may see that things work in a certain context, but when you engage communities into that translation process, you see that the outcomes are much, much better. The capacity building, of course, bidirectional learning, and just increased trust on both sides. When you're engaging communities in the research, they're more invested, the collaborations are stronger, and both partners can really benefit. So thanks so much for listening.
Thank you, Jay. I'm a newbie in intervention research. I'm doing an RCT with John Pachankas, but also trying to develop an intervention for sober curiosity among sexual minority women. I learned a lot, and I appreciate you being here to tell us about this stuff, and I'm gonna tap you to help me figure out things. I want to introduce Casey Jackman. Casey is an assistant professor in the School of Nursing and wears many hats, which I'll let him tell you about. But Casey's going to moderate the questions, and I assume we're on Zoom. We didn't see faces up here, but I'm hoping that those of you out there in cyberspace have enjoyed the presentation as much as we have. So I'll turn this over to Casey and to those of you who want to ask questions.
Do we have any microphones, any handheld microphones? Excellent. Two, perfect. Thank you so much. Yes. Hello? Yes. All right. Well, first, I just want to thank Jay. Jay, that was wonderful. The way you brought us from theory all the way through to practical application of every stage of the NIH model of intervention development and dissemination, implementation, was really a tour de force. And the breadth and depth of your work and your long-standing commitment to the trans community, those really came through for me. And I'm delighted to now open it up to questions from the audience. I know we have here in the audience students and trainees of various levels, as well as faculty of all levels. And so I will walk around and give the microphone to whoever has a question and facilitate the discussion. So who would like to go first? How about we go here to Anna, and we will make our way around.
Hi, thank you so much. This was a wonderful presentation. My name is Anna. I'm a first-year PhD student, and I'm interested in culturally adapted mental health interventions for Latinx patients. So there's a lot of overlap. It's just, yeah, it was wonderful. I learned so much. I would really be curious to learn more about kind of the process for, given your clinical psychology background, and how did you decide what aspects of the interventions to adapt? In the work that I've seen with culturally adapted CBT, motivational interviewing in the behavioral health space, I primarily see adaptation work that is focused either on implementation or on content. And I think you touched upon that a little bit, but given that this is work that I see myself pursuing, I would really, be curious to hear sort of the decision making and kind of what informs the aspects of the intervention that you adapt.
Mm-hmm. Yeah, it's such a good question. Thanks for asking that, Anna. I think the decisions about what to adapt, I think that is really where community engagement can be so critical and so important. Because often what we'll do is with the intervention working group, we'll review the intervention, the unadapted intervention, the original intervention together, and kind of get people's input on what feels relevant, what doesn't feel culturally appropriate. But ultimately, I think theory is also really important in deciding what to adapt. So for example, the T-SISTA adaptation of SISTA, SISTA was originally informed by the theory of gender and power. So there was a lot in SISTA around gender and power and elements that felt important to retain, but the context was really different. So it was about, cisgender women. There was like things around, being a mother, or, things that just didn't feel as relevant to the adaptation. So we retained the theory of gender and power, but we added the model of gender affirmation. And so thinking about what does gender and power look like in the context of not being affirmed in your gender, and how do we adapt some of the activities to think about, how power operates when somebody is not feeling affirmed. How can we incorporate gender affirmation into the intervention itself, where this is a place where people come to feel affirmed, and also to understand how people can affirm each other and also affirm themselves. And so giving people lots of tools around that became an important part of the adaptation. So I think thinking about the theory that the intervention was originally designed around, and what you might want to add, can start to really inform what you adapt and how.
Yeah, thank you. Does that answer your question, Anna? Okay, great. I think I saw another question up here. Did you have a question?
Jae, excellent talk for many reasons, and it was a helpful framework and lecture, essentially, for me as someone who's kind of entering intervention science. My question has to do with kind of community engagement. You've talked about the importance of it. I think everyone buys it, and I appreciated the different iterations of how you've described it and how we kind of come at it from different disciplinary perspectives. Can you share a little bit about what you've done to engage the communities? Perhaps, or I'm especially curious to hear what you've done in a different context. So for example, in Brazil, how did you engage that work? How did you start that work? How did, logistically, as a researcher, did you travel there? Did you live there? Those kinds of thoughts.
Okay, yeah, many questions embedded in that, and I'll try to answer all of them. Let's see, the first thing, what did I do to engage community early on? It's been interesting because if I didn't mention this already, I worked in San Francisco for 20 years before coming here to New York 2 years ago. So changing community context has been really interesting for me. It's like learning a new community, essentially, because I tend to work very locally. In San Francisco, when I started the work, it was 20 years ago. I was younger and much more energetic then. So I went to every event. I was at Trans March. I was at every TDOR event. I was at everything. So it was just about being with community at first for me, and just really getting to know people, getting to know who are the leaders, who are people that people really look up to, role models. I also had an incredible mentor in this, Joanne Keatley, who I know Sabrina knows, who also I got to kind of follow her around, and she was very well known in community. And so the more that people got to know me as a person, the more trust was built. And so I think that just showing up is a big aspect of those initial stages of community engagement. But then it's also about bringing people into the research process and acknowledging their expertise. And acknowledging their expertise can look like paying them for their time, being really open to learning from them, showing how your research is changing as a result of their engagement, giving them the opportunity to speak about the research rather than always being the one to speak. So different things that, really intentionally addressing those power dynamics that can very easily be created and reinforced through our more traditional dynamics with community. So thinking about that. Brazil was an interesting development. I didn't anticipate necessarily going to Brazil. I grew up in Miami, so I grew up in a very multicultural, lots of Brazilians in Miami. So I'm very familiar with aspects of the culture, but my collaborator, Sherry Littman, was working with female sex workers in Brazil. And there were a lot of trans women who wanted to participate in her projects. It was a very community engaged project, but she didn't have any expertise in working with trans women. So she said, do you want to come with me to Brazil and do this work? And I was like, yes. And so, it turns out like, because she has a very community engaged approach and tremendous community partners there, we ended up partnering with a community-based research group there that does specific work on the ground with sexual and gender minority folks, and has a lot of connections to trans communities. So a lot of my work in Brazil is with that partner who is also incredibly community engaged. So they're really the leaders in that context.
Thanks, Jay. More questions, yes. I'm loving learning the nitty-gritty, the details, the personal experience you're sharing with us. This is really interesting and helpful.
Thank you so much for this. So following on that last question, actually, you mentioned some of the difficulty funding those, the building the partnerships. And something some of the PhD students here at the School of Nursing got this week was a lecture from someone who is actually a program officer at PCORI, where they've, talking about their engagement awards, both for, I guess there's 3 categories, dissemination and the original engagement and one other, but I was curious if you, what your thoughts about some of those things were, or what your perspective on the challenges of securing that funding, if that is do you feel like that's going to increase? I think PCORI was talking about how they've actually had to be so selective because it has exploded the number of applications around these engagement grants to do that partnership building. And I was curious, as someone who's been in this work, if you think that there's room in other agencies or otherwise for this to explode there too.
Absolutely, yeah. I think you sort of answered that question right at the end there, because I think PCORI is super unique. PCORI didn't exist when I was first doing this work, and I think probably the reason that it's exploded is because they're so unique, and because there really aren't a lot of other sources of funding for that kind of partnership building. I have not applied for a PCORI grant. I've thought about it. It's structured so differently from NIH, and I'm so embedded in the NIH world. I mean, I've written some state grants and some foundation grants, but PCORI is it's a huge undertaking to write one of those grants, and mad respect for the people who do it. I'm actually an advisor on a PCORI grant that's looking at peer navigation for transgender women who are getting gender-affirming bottom surgery. So it's been super, super interesting. That is Giolani Dye out of Oregon. You know Gio? Yeah. They're amazing, and they have this huge PCORI grant involving a ton of partners, and they've been in the process of training up all their peer navigators. But I think it's just it's really, really cool work. Yeah. I hope that answered your question. Yeah. Okay.
Great. And our next question is from Sue.
Hi, I'm Sue Bakken, Vice Dean of Research here in the School of Nursing. And actually, it wasn't so much a question I wanted to add to the information you provided, and just reinforce the importance of community and public engagement. And NIH is making strides in that area. I'm the co-chair of the Engaged Working Group at NIH, and so we've been charged over 2 years with creating a framework, a toolbox, and some other kinds of things. And so I think, I'm hoping, so anyway, the 2 years we'll have a set of things and some recommendations, but I think many different agencies have come to realize the importance of it. But so I'm really hoping that in the future, there will be more of an engagement requirement in the funding to go along with it and what we do with NIH funding, so things actually end up being implementable. I'm happy to have a side conversation about PCORI sometimes, because I'm on the PCORI Methods Committee as well. So,
Amazing.
But I'm happy to chat with you. I spent 21 years at UCSF before I came here. So,
wow,
but,
we'll have to chat.
I was leaving in 2000, probably right as you were starting here. So I've been here 25 years. Yeah.
Wow. Yeah, and I love what you said. Wow. I think get the prize. Yeah, I love what you said about that it's really helpful for NIH to acknowledge and maybe even require the community engagement, and to have that funding that goes along with it. Because I think Currently, study sections and things like that, you'll hear people, want a lot in terms of community engagement and, want to see that piece. But the funding the funding hasn't changed in so many years, and it's really, really tight, these budgets. And so, people do the best that they can, but to see NIH really step up with funding for community engagement would be amazing. So thank you for that.
Yeah, it's real talk about the money it takes to do some of the work. Our next question is from Susan.
Hello, thank you so much for your talk. I'm Susan. I'm a second-year PhD student at Columbia. I was just so interested in a lot of what you said, and especially kind of the process of doing interventional research and establishing those relationships with the community, really understanding where the disparities lie and kind of what's leading to some health disparities. I'm very interested in sexual risk-taking behaviors among transgender adolescents, and I'm putting in F31 now, kind of looking at the relationship between state-level policies and sexual risk-taking behaviors. But I'm wondering about your thoughts on when to start doing intervention research over, a career trajectory, because I think establishing that understanding of the disparities, especially in a field where maybe there's not a lot of knowledge on the topic, establishing yourself with the community, building that trust, and then, starting doing the interventional research. Is that something that you think you really build up to in a career, or something that you can start working on pretty early?
I think it's just like anything else. And I only have my own experience to really speak from, but even just, working with, a lot of mentees over many years too, I think you really can plug in at different points in the intervention process. I think it really depends on what type of intervention work you want to do and the community you want to work with. If there aren't interventions that already exist for the type of work that you want to do, or maybe there's not even a lot of formative data around it, then maybe that really is the place to start. But there are some folks who are really, really just interested in implementation. And there are a lot of efficacious interventions that we still don't understand how to implement or how to optimize implementation. And so it's really about understanding the implementation context, and you can do that in very community engaged ways. So I think really it depends, it sounds like, the question that you're asking, there's a lot of innovation in that, there's a lot to still be learned in that context, so maybe starting with the formative studies. The benefit of starting with formative studies too, especially if you're gonna go into development, is immersing yourself in those contexts, really learning from the people that you want to impact in the community and really hearing it in their voice. I think that was transformational for me, and it also just solidified my passion and commitment to the work in a way that I'm not sure would have been the same if I had gone right into, say, implementation studies. So I think everybody's a little bit different, and I think it's possible to plug in at any point.
Thank you. I do want to encourage anybody watching on Zoom to put questions in the chat. We don't want to ignore your questions, so they'll be communicated to us if anything is entered. Other questions? Yes.
Thank you so much. Every time I listen, it's more and more new stuff that I didn't know about. I'm wondering about your experience with adapting versus creating from scratch. I think creating from scratch is very challenging, but a lot more authentic. And I propose, just disclosure, several NIH proposals that really got very critiqued for what is the developmental process. So I'm learning from the community, and I have these questions, and the literature is telling me this and that, but I'm really going to hear them out and to listen. And it was every time it was so, it was not received well. They all just wanted to know more of the core components and basically adapting. Mm-hmm. And then I honestly have never been able to build an intervention from scratch because it never got funded. Mm-hmm. Obviously, there are other reasons, but I really think that was the core of distrust that this process is going to lead to something that was rigorous and would have an impact. Do you have any thoughts on that?
Yeah. I do think that some of that is even just grants personship, because it's very similar to what often happens in like K awards, where you say, you're like going to learn about these methodologies and you're going to learn about the community, and then you're going to develop and pilot test an intervention at the end. And the reviewers want to see the intervention in the proposal, even though you don't know what it is yet. And so typically what I see work well is when you have an example of an intervention. It could look like this. These are the types of things that we would consider including, the types of components. Here's a similar intervention to what we think it might look like. And then that way you're also mapping out sort of the methodology, your timelines, what the budget you're going to need according to this like example intervention or what you think it might look like. And then you're also giving yourself the room to adjust according to what you learn actually from community. So your intervention that you end up with at the end might not look anything like what you put in the proposal, but the reviewers want to see that you know what it might look like. Are you budgeting correctly for that, or do you have the timeline for that? Do you know what intervention components might be? So it's I've worked with K awardees on this a lot because of a similar issue. So it ends up just being like grants personship. You just have to give them what they're asking for, and then know that you're going to do what you need to do to get to the intervention you want to develop.
Got it.
Great. I think we may have time for one more question, if there's another one. Oh, over here, we have a question.
I see Jae all the time. Great talk. Thank you so much. I just wanted to say to you, I had my very first grant slammed 3 times. I was completely ready to throw in the towel to NIH, and I'm here a lot longer. So I'm curious just about, you actually made a really great point, I think, but one that study sections challenge sometimes, which is pilot studies are meant for looking at feasibility and acceptability. And so for people who are struggling a little bit with, especially K awardees, right, with no money, conducting formative work, developing something, and then piloting it, how do you suggest getting around this? It really is about feasibility and acceptability. You don't have the power to necessarily show anything, but review committees basically wanting you to write a mini RO1. Does that make sense?
Yeah. So, my statistical mentor, Tor Nealons, he kind of says this to everybody, but he's also taught me sometimes, the way that I have done it that has worked is to just educate the reviewer in the grant. So there's some really good citations, I'm happy to share them with anybody who's interested, that talk about here is why efficacy testing or using it to estimate sample size or estimate effect sizes is not okay. It's not statistically valid use of that pilot data. And so you can educate the reviewers in your proposal, you can give them the citations. The other thing that you're pilot testing, say at the end of a K, for example, if you want to go to the RO1, you're piloting your RCT methods. So I really like to try to encourage K awardees to do a pilot test that we're also piloting randomization. You can randomize 2 to 1 if you want to get more information about the intervention, but you have to pilot the randomization strategies, you're piloting your data collection tools, and so you're piloting all the things that you're going to need for the RO1 too. Can you conduct that study? So it's not just about piloting the intervention, and then that you're giving the reviewers something more to show that you're ready for the RO1. Another way that I see some researchers do it, which is like, I think kind of, trying to walk both lines, where they're like, we know this effect size estimate is really not statistically valid, but we're going to get one anyway just to see. just to see what it says. But it's like, why? When you know that it's not really, you're not really valid for using it for that purpose. So I try to do the Dr. Nealon's method of educating the reviewers.
Excellent. Well, we're gonna, I think, oh, we have a question from online. This is exciting, all right. This will be the last question.
Okay, this is from someone in Thailand. Their name is Nanchansen Sakupong. Hi, greetings from Thailand. Thank you for your insightful presentation. I have a question and would greatly appreciate it if you could share your experiences. In my research with psychological interventions for Thai transgender individuals, I often encounter the issue of internalized transgender stigma within this group. This tends to be a significant obstacle in achieving the desired outcomes of the intervention. I'm curious to know how you address this issue in your interventions. Thank you.
Yeah, great question, and thank you for joining us from Thailand. That's super exciting for us to hear from you, so thank you for that. Yeah, this idea of like internalized transphobia, I think it's really pervasive, and it's a product of stigma and marginalization, and I think that sort of it's not a timeline, but like a flow chart of the formative research and like how external stigma gets internalized and enacted through like behavioral health, behaviors, and ultimately health outcomes. I think that is where we really think about like, okay, how does gender affirmation interrupt that relationship, right? Internalized gender affirmation is just a way of internalizing the stigma that you encounter around you. And so one of the things that we build into, we build many things around gender affirmation into our interventions, but a lot of it is about really creating environments and creating community where people are being affirmed for who they are and experiencing that level of gender affirmation, and also understanding how stigma can get internalized. And so really thinking about the ways in which things like family rejection impact how we think about ourselves and how we think about our identities. And so I think it can be very multi-pronged, where you're increasing someone's sense of social affirmation by building community. You're also educating people about how their self-image has been impacted by maybe past trauma, and giving people tools. One of the things that we do in Shiro's, for example, is we profile different like prominent transgender women leaders and talk about their stories. And so it's a way, and that was something that was actually in SISTA as well, where you talk about sort of the accomplishments of your community, role models, people where you can start to see yourself reflected in people that you look up to and feel. Start to internalize that sense of value and worth, and also give people tools to be resilient against stigma. So recognize when it's happening in the moment and choose not to internalize that, and give people tools for how to do that. So I hope that helps.
Yeah, wonderful. So I think with that, we're going to conclude the formal question and answer session. However, there's now a reception. So we're going to continue the conversation over some food and drinks, which are in the back. I want to thank Jae one more time for sharing their wealth of knowledge and experience with us. This was a fascinating, very valuable talk. So thank you, Jae.
Thanks, Casey.